I think I'll just go ahead and introduce our first speaker, Dr. Sherwin Arman. He is going to present on functional anatomy of the masticatory system as well as TMJ imaging. Please understand that in 50 minutes, it's a very compacted opportunity to go through this material, but I'm sure he'll do great. Dr. Arman is the director of the Orofacial Pain program and continuing dental education at UCLA School of Dentistry. He joined the faculty in 2012 and then also had a practice limited to orofacial pain. He is a council member at the board of council board of the AAOP, as well as participates in the ABOP. His interest is to promote orofacial pain education to healthcare providers and students, as well as the integration of orofacial pain education into the dental curricula. Welcome, Dr. Arman.
Thank you, Dr. Millett. I really appreciate it. I think that this pre-conference is really a great idea. We can kind of build on the foundation for orofacial pain. Feel free to ask any questions along the way and at the end. So let's just get started. So this lecture is going to be focused on what we're going to call and what is the functional anatomy of the TMJ, but also, we should differentiate some terms here. The TMJ, you got two of them. And then there's TMD, okay? Whenever you hear the term temporomandibular dysfunction, it includes a lot more than just the two joints. It includes what we're going to talk about today. It's going to include the muscles of mastication, which we'll talk about. It's going to include even the upper cervical muscles. So let's just get that out of the way. We have TMJ and we have TMD. So the outline of today's lecture, we're going to go over the joint because our focus is on the joint in some cases. From a clinical perspective, I will tell you this from experience, when pain is the driving factor, or even other conditions, our focus should not only be on the joint. The vast majority, or at least we should give equal time to the musculature and soft tissues. It always gets me when a patient has been managed for quote-unquote TMJ pain. They've had injections in their joint, but nobody performed an appropriate evaluation of 1 inch away into the masseter muscle, and that was the source of the pain. So just keep in mind that when you are managing quote-unquote TMD conditions, a proper, complete evaluation just may uncover the fact that it may really not be the joint itself. Nevertheless, we're going to learn the anatomy of the joint and what are some common dysfunction and also what normal function looks like. Before we can talk about dysfunction, we've got to know what the joint looks like and how it operates. We'll get into the muscles of mastication. We'll talk a bit about blood supply, innervation, some of the important aspects, both in terms of what innervates the structures and some considerations regarding treatment. Like, what do I got to be worried about if I stick a needle here, for instance? I think that's an important thing, And then we'll get into imaging. Do I just send every patient for a CT? Do I send every patient for an MRI? What's the workflow? What are we thinking? When do we send for an MRI, CT, cone beam CT, panoramic, and so forth? So we'll talk about what we think about in making that decision. So let's start with our friend here, the temporomandibular joint. Okay. Now, it's quite a unique joint. It has a lot of aspects to it. We've got the condyle right here. We've got the temporal bone above it. Okay, we're very comfortable with joints. We have an articulating surface. When we open our mouth, the first 20-25 millimeters, the joint is going to rotate in place. It's not going to go anywhere. It's just going to rotate. After that, it translates down what we're going to call here the eminence. There's some terminology. The eminence. It's going to translate. So you have rotation followed by translation. Okay, that's why it's called a gingumo-arthrodial joint. You have rotation and translation. We have this wonderful aspect of the joint called the disc. This disc is a source of great concern. It brings in patients for evaluation, for treatment, because this disc can cause symptoms such as clicking, such as locking. And you've got to learn how to tell when the mouth doesn't open, whether it's really because of the disc or maybe it's from a spasm. Maybe you have a masseter spasm. Okay? Certainly we have two of them. It could be one-sided, it could be both-sided. And I'll just tell you that when it comes to management of a clicking joint, if there's no pain, the standard of care is no treatment. I'll tell you right now. Because there's no way that you're going to, number one, recapture that joint reliably, and number two, invasive procedures that have been done to open up the joint capsule and basically staple that disc onto the condyle have led to worse problems. Neuropathic pain, fibrosis, and so forth. So, painless click, leave it alone. What we can see in front here, anterior, is the lateral pterygoid. We'll talk about the lateral pterygoid. It's what pulls the mandible forward. This right here is one of my favorite muscles. If anybody here gives management to sleep disordered breathing, does anybody here do MADs? Does anybody here? You do. What's one of the main side effects? Bite changes. Now, it could be from tooth movement. Absolutely, that's a part of it. Another thing is 8 hours, your mandible is forward. You wake up in the morning, and you're class 3. That lateral pterygoid has shortened. All right? So we'll definitely talk about how to get to that joint and how to get to that muscle if an injection needed to be done. But just know that there are two aspects to this. If you look down here, you have the inferior aspect attached to the actual mandible, the condylar neck, whereas the superior aspect is attached to the disc itself. In fact, one treatment for patients who have chronic open lock, they have an open, they're locked open. There are several different treatments. One of them, oral surgeons may go in here and actually snip off this aspect to have less of an anterior pulling on the disc and the condyle itself. That's one thing. So when we look at the condyle, it's going to be in contact with the inferior surface of the disc, and we have this disc, and the superior surface is in contact with the temporal bone. When I stick a needle in this joint to do a steroid injection, I want to put hyaluronic acid in the joint. You do a 2-needle arthrocentesis, an arthroscopy. Where are we? Inferior or superior? We're superior. That's where we're at. This is the superior joint space. Just when all of this comes down and translates down the eminence, this space opens up. That's why. So if you ever wondered, or maybe now you'll think about it more, that's where we're putting our therapeutic treatments in the superior joint space. When it comes to pain, I want you to pay attention to the posterior attachment. This is the area that is vascularized. It's innervated. So although you can have pain in the actual joint capsule itself, you can also have pain in the posterior aspect. In fact, what we'll do is we will take the patient's mandible and we'll kind of push posterior to compress those tissues when we're trying to test to see if the patient has pain that's coming from the joint. So the posterior aspect is innervated and highly vascular. The disc itself is not. The disc itself doesn't have no nociceptors. All right? So, before we can get into dysfunction, we got to talk about function. And when we look at this normal mechanic slide, I want you to note that I'm going to come back. We have two bands to this disc. We have the posterior and anterior band. And this middle portion is thin. In a resting position, the posterior band is actually at the 12 o'clock position, superior to the condyle. Okay? One reason is because you're tugging anterior from this lateral pterygoid muscle. So that's actually normal, that it's a little bit looks forward. And when we look at the MRI later on, we'll see what it looks like functionally. So the normal position is the 12 o'clock position will be where this posterior part of this disc will be situated at rest, and that is normal. So that's why we've shown it in that way. So this is a biconcave disc. Biconcave, you have the anterior, the little hump, then you've got the posterior, the hump, and in the middle, the thinner intermediate zone. So in a normal situation where there's no dysfunction, you open your mouth, you get your 20, 25 millimeters, and then you start translating down the eminence. Okay? You could reach what we'll call the crest of the eminence, this little, right here, the actual tip, and a lot of times you can go beyond. That's not abnormal. So my question is, what happens if somebody has an open locking issue? What's going on? What's probably happening is that the posterior ligaments have become elongated. Okay? Ligaments are there to protect the joint. They're there to limit motion of the joint and to allow functional movements. It wants to allow a certain amount, but not too much. What we have to deal with is that ligaments are not very elastic. Once they elongate, they're elongated. So when you've got a clicking TMJ or you've got open locking, those ligaments are probably elongated and they're going to stay elongated. So what's considered a normal opening? Well, that's an easy answer. It's 40 millimeters. That's pretty straightforward. Now, you've got to take this still with a grain of salt. You'll have somebody who maybe their normal is 37 millimeters. That doesn't mean that you have to initiate aggressive treatments to get them to 40. But nevertheless, 40 millimeters is considered a normal opening per criteria. Now, what happens when you have a clicking joint? What's changed? Well, remember, the posterior ligaments, the retrodiscal tissues, those ligaments have elongated. And now, this posterior part of the disc is now sitting forward to the condyle. It's a little bit forward. It's no longer at the 12 o'clock position, it's at the 2 o'clock position. Okay, so all these ligaments have elongated, so it's sitting here. So what happens? You open, and you get a click. You get a nice little pop. Sometimes it's painful, sometimes it's not. If it's not painful, it's not worsening, there are no other issues, what did we say? Standard of care, leave it alone. Because if a patient didn't have pain, and now you're doing something to treat a painless click, they just might end up with pain, and they never had it. Okay? And it's not uncommon that you might get a reciprocal pop as well. You're going to close your mouth and get a pop too. No big deal. So it's going over the posterior aspect, the posterior band of this disc. What about when you get locking? So we went from normal to a clicking TMJ to a painful situation. So once again, this disc is anterior. It's anterior to the 12 o'clock position. You open, and now it's stuck. So I'm going through a progression about what somebody might experience. You start with a non-clicking, non-painful TMJ. You then get a clicking TMJ. And now, every now and then, it's going to present as, every now and then I get either a painful click or I get locked. And then my question is, well, how long do you stay locked? Can you maneuver out of it? A lot of times you can maneuver out of it. The patient moves their mandible side to side and so forth. Okay? So at this point, what's happened is that this disc has probably changed morphology to the point that it's kind of crumpled up and it doesn't look too great. Probably it doesn't look too good. But even so, we're going to stay conservative with this treatment, especially if the locking is not chronic, if a patient is not just stuck, locked. So what about, before I move on here, so what happens if a patient is locked? What if this disc is now crumpled up and you can't open beyond 20 millimeters? What do you do? What do you do? Well, again, we're looking at a more basic case, which is the most common case. There's no pathology. There's nothing terrible going on. You have two choices. One, you actually can have the patient stretch and keep pushing this disc out of the way. This disc will just keep moving further forward and forward. So the question I get is, well, what happens to the condyle? What happens to the joint? Well, what are you sitting on? You're now sitting on the ligament. Does that make sense? Right? This disc is out forward. You have your ligament. So now you're sitting on the ligament. And you're going to form a pseudodisc. Just like when you do yard work, you do a lot of wood shop, and your hands get callus formation, right? It adapts. And you're going to get a type of a pseudodisc. And yes, that's okay. That is okay. Because I'll tell you that if somebody goes in there to try and get the disc back in place, you tell me why this disc won't slip out of place. Happens all the time. Happens all the time. The TMJ gets so much attention, but really we should be focusing on the muscles equally as much, and we are, probably actually more today. Because when it comes to pain, which is really the number one reason why a patient will come for treatment, the muscles are where we should be looking. The muscles are really where we should be looking. And when we are looking at the muscles of mastication, most of them have innervation, have blood supply from the maxillary artery. I'll show you why this is important soon. But we have the medial pterygoid, lateral pterygoid, masseter, temporalis. Those are the main four, the big four. And then we have others as well that are kind of given, that are treated as second fiddle. But those are the main four. Okay? So these are the main four. So the maxillary artery gives blood supply to the masseter, medial pterygoid, lateral pterygoid. And then we have the superficial temporal artery that gives blood supply to the temporalis. These are branches off the external carotid artery. Okay? All of them are innervated by the trigeminal nerve. V1, V2, V3. It's all from V3. V1 and V2 are purely sensory. There's nothing motor coming out of either one. Even the temporalis, even though the temporalis is here, it's in the V1 region, V1 is only giving sensory information, sending sensory information to the central nervous system. The muscle of mastication, these four, it's going to be from the third branch of the trigeminal nerve only. So I just mentioned, and I do want to give a special shout out to the accessory muscles, because we simplify our lives. We talk about the big four, but oftentimes the suprahyoid and the infrahyoid muscles are included in the list of muscles of mastication. The practical significance will vary. As you can see, there's a lot going on in the neck. I think that providers, understandably so, are going to be a little bit hesitant to stick a needle and do trigger point injections in this region. And that's probably why it's not done. But what we do have to pay attention to is the anatomy, so that we know how to palpate, and to be able to properly at least diagnose where the symptoms are coming from. Maybe we have to send a patient for an MRI of the neck. Who knows? We should be doing an evaluation nevertheless. So what do the suprahyoid muscles do, and what are they, and what do the infrahyoid muscles do? So the suprahyoid muscles, if we're going to focus in on these, it's these four. Mylohyoid, the anterior belly of the digastric, okay? We have the posterior belly, and the stylohyoid. For the most part, what the suprahyoid, and it's muscles above the hyoid bone, what they do is they open the mandible. They're opening muscles. That's what they do. Okay. The innervation will be either V3 or it will be the facial nerve. It will be one or the other. But they all do pretty much the same thing in terms of opening the mandible. So in any orofacial pain evaluation, not only are we going to appropriately palpate the TMJ, we're going to note where the click is. Is it an opening click? Is it a closing click? Is it one-sided? Is it both-sided? Measure the opening. We have to do a complete neck exam as well. Myofascial trigger points. Referral. Remember, site of the pain is not always the source of the pain. You might palpate the sternocleidomastoid and get a referral pattern to the temporalis. You could do all you want to the temporalis, that's not where the pain is coming from. Everything in up, down, or down into the C2, C3 region in the C-spine, all of those sensory fibers actually end up in the same place, in the subnucleus caudalis. When you treat migraine, I'll tell you where I'm going with this, with the Botox protocol, with the Allergan protocol, you're even injecting into the trapezius. And you're treating migraine because all of the sensory fibers end up in the same place that sensitizes the trigeminal nuclei. So we can't just be focusing on the masseter and the temporalis. We have to be comfortable with at least being able to identify sources of pain in all the structures that can sensitize the trigeminal region. And that's down to about the C3 region in the cervical spine. There's a lot going on down here. Look, you have the floor of the mouth. Who feels comfortable in, putting a needle in there? I always recommend, getting some sort of guidance if someone's going to do that, whether it's with EMG, preferably with ultrasound to see where you're going. Sometimes we do. The more important point I wanted to get to was this right here, to really show all the structures down here. The reason I wanted to show this slide and kind of get away from the big four muscles of mastication is that we have muscles like the medial pterygoid. But look what you have to get through to get to the medial pterygoid. It's a lot. It's a lot of structures there. And if you inject it, you're going to be getting into virtually the attachment points. But nevertheless, you've got to be able to palpate appropriately and make sure that you can differentiate between joint versus muscle, and then if you've found a painful area, to determine whether you have a referral pattern. You've got to hold the palpation long enough. That's the takeaway point here. Lots of structures, and appropriate palpation and evaluation are necessary to know where it's coming from. Now, when we get back to the big four muscles, I love the masseter muscle, and so should you, because it's big, it's accessible, and it's a pretty safe muscle to treat. There isn't much there, as opposed to the previous slide, with all these arteries, veins, nerves. You have the trachea. This is a great muscle, and it's a superficial muscle. You can just find a trigger point. You can find a taut band and the trigger point in the taut band if you need to. I love it. What does it do? Well, it elevates the mandible, and you can tell from where it's attaching and inserting. The origin is in the zygomatic process, and it inserts into the mandibular ramus. So it closes the muscle. It closes the mandible. So if you have limited opening, this is a muscle that we have to make sure is not a contributor. Because if this is in spasm, if this muscle is stiff, maybe that's why. I try and open the mandible. I get in there with some cold spray to try and open the mandible. And it's a hard feel. It feels like I hit a wall at 25 millimeters. I start thinking, maybe it's not soft tissue because it's a hard feel. Maybe it's because the disc is out of place and it's blocking the condyle like we saw. But what if the patient opens to 25 millimeters and you're able to push through and get to 35? So when you've got that soft end feel, that's more of an indicator that you may have a soft tissue restriction going on. So those are two terms that you've got to be familiar with. A hard end feel, where patient opens to whatever, 20 millimeters, and you try and push further and you just can't go. as opposed to a kind of a springy motion that you can kind of push through it that is soft end. Okay? What if you have a limited opening and you have a deflection to the left side? It deflects to the left. What do you think may be going on with a hard end feel? If it's going to the left and it's hard, this is how you got to be thinking. Well, I'll tell you what that means to me. That means that the right side is translating, the left side isn't. Because this side's still going, so it's deflecting to the left. And it's a hard end feel. So that's a little bit of evidence that says maybe, number one, it's joint related, and number two, it's because the disc has been displaced and it's blocking that condyle. Okay? So you're always going to deflect when it comes to the joint, you're going to deflect to the side that's locked. You're going to be deflecting to that side. Any questions on that? I'll make sure it's clear. Now, this is the masseter, and I'm showing you the facial nerve. Now, I told you that this muscle is not innervated by the facial nerve. The motor is from V3. The reason I'm putting this here is to show you where other structures are running in relation to the masseter. When I perform trigger point injections into the masseter, like I said, I'm not too worried. We use a very small 27 gauge needle, we aspirate. Not too much that can go wrong. Even if you have nerves, look, you've performed nerve blocks all the time, you perform them all the time. Nerves are small, they're slippery. It's really hard to actually put a needle in a nerve. But one side effect that patients can get is they can't close their eye on that side. So I always let patients know, and I'll show you why. I'm not going to leave you hanging there. The zygomatic branch of the facial nerve. That's why. The zygomatic branch of the facial nerve. That closes the eye. Okay? So, I'm not done with that yet. So let me just tell you why. If we look at where these nerves are running, in this way, in a cross section, it's just under the skin. It's not that deep. It's quite superficial. It's very superficial. So, you got to go, half an inch maybe, and you can perhaps catch some of the branches of the facial nerve. So I always let patients know, I go, look, you know how you go to the dentist and your lip gets kind of droopy? Well, this may happen to your eye too, or just feel weird. Don't worry about it. We're all used to this when it happens on our lip. We're not used to it when our eye starts to do weird things. So that's the practical point of this. Very safe muscle to inject. Really, quite safe. But the facial nerve can be affected. The temporalis muscle. Another one of my favorites. It's a superficial muscle. You can feel it. You got to watch out for the temporal artery, though. But even that is quite superficial. You can palpate it, even if you can't see it. Make sure you don't put anything in there. Now, in real life, even if you get into an artery or a vein with something aqueous, something like lidocaine or something, chances are nothing's going to happen. Okay, that's the truth. You really run into problems when more viscous solutions are placed, like fillers, hyaluronic acid, Synvis, because that can lead to occlusions, peripheral necrosis, because you've blocked the blood vessel. It can lead to embolism and stroke. But when it comes to the watery solutions, you're dealing with more of the peripheral issues, such as bruising and so forth. So what does the temporalis do? Well, when you look at where it's inserting and originating from, it's in the temporal fossa and the coronoid process of the mandible. So when you look at where the fibers, how they're running, it also is a closing muscle. It pulls the mandible upward. So the masseter, temporalis are closing muscles. One mildly complicating factor here is you've got the tendon here the temporalis tendon, and you've got to be able to get in there sometimes and palpate. It's usually easier to palpate it intraorally because this, if you look here, this is indicating that this temporalis tendon is inserting on the medial side. It's inside. So that's why intraorally is a little bit easier to palpate the tendon. A lot of times just by rest, soft diet, things can get better. Sometimes you'll put some steroid in there. When you put a steroid next to a tendon for tendinitis anywhere in the body, you don't really want to go in the tendon like you would with a trigger point. You really want to go adjacent to it and put a touch of steroid. And of course, too much steroid too often is harmful because it doesn't play nice with collagen. Same with joints. You put too much steroid, the joint can actually effectively degenerate. So you got to be careful with too much steroid use as well. Back to my real favorite muscle here, which is the lateral pterygoid muscle. Can you palpate the lateral pterygoid muscle? I'll tell you right now, you can't. You cannot palpate the lateral pterygoid muscle. Remember all those slides I showed you with all these layers here and here? You would have to palpate so hard and so deep, you're going to cause pain with other structures before you got to this muscle. I don't know how you would tell that you actually elicited pain. The way we would test this muscle is indirectly. Indirectly. So how do you do it indirectly? Well, we know what it does. The mandible, it pushes the mandible forward. It pulls it forward. So what you do is you push back and have the patient try and push against your hand. So you're loading the muscle to see if it hurts. So that's resistance testing. That's how you would test muscles that you can't physically get to. If you can't get to the medial pterygoid or the lateral pterygoid, you're going to test it through resistance. There's no way you can palpate it, or at least be reliable in your palpation. So, another test. What if you have a spasm of the right lateral pterygoid? What's that going to do to the mandible if the right side is in spasm? Right side's in spasm. Where is the mandible going to go? It's going to go to the opposite side. It's going to go to the opposite side. So that's why you have to play these mind games about what happens if one side is locked, if one side is in spasm. How does that present clinically? If you have a disc displacement on one side, you try and open, you're going to deflect to that side. If you have a spasm of the lateral pterygoid on one side, it's going to deflect the mandible to the contralateral side. So then you could do a trigger point injection, you could do Botox, and so forth when you do that. So looking again in the realm of the lateral pterygoid, what's running around there? Well, you've got the maxillary artery. You've got our good friend, the maxillary artery here. For the most part, the things we could potentially inject, it's going to be either some sort of anesthetic, maybe Botox. Still pretty safe, unless someone's got some bleeding disorder. But just know that is the one structure that you're going to be needing to watch out for. And by watching out, you're going to aspirate, which you always do anyway. Make sure don't inject anything in there. The practical aspect of that, like I mentioned, with what you'd be injecting there anyway, would just be you would lose therapeutic value. Botox is pretty expensive. I don't think it's good to inject it into an artery when you really want to get it into a muscle. I'm not really too worried about anything terrible happening because it's an aqueous solution and probably nothing will happen. But the injection, the way I like to do it is extraorally through the notch, right? You have the coronoid process, you have the coronoid notch. So you get in here. You can use EMG. We use something called a myoguide. We have ultrasound. We'll talk about that at the end, whether what we're using it for. That's a little bit more, it takes a little bit more practice to use ultrasound, especially in a small space. You almost are blocking yourself when you're trying to inject, as opposed to a knee. This space is so small, it could be a little bit cumbersome. The medial pterygoid. This muscle is also a closing muscle. And you know that because you've got attachment, or the origin is over here in the medial portion of the lateral pterygoid plate. And at the condyle as well, on the ramus and angle. Okay, the ramus and angle of the condyle, of the mandible. So this is also a closing muscle. How deep is the lateral pterygoid? I'm going to still go back. How deep do you go? Let's say you don't have guidance. I think this is important. Half of my colleagues don't use guidance. Half some guidance like EMG and so forth. How deep? What's a average distance? You know, about 1.5 inches. And actually, one way to go about it is some people actually go in and will hit the pterygoid plate. So they're coming in, they'll hit the pterygoid plate and then pull back and be in the lateral pterygoid, the green here. So you'll come in from the notch, this side, bam, you hit, and pull back. Like I said, not too many terribly dangerous structures there. I mean, as long as you aspirate, just give a nice ice pack and make sure nobody has any significant bleeding issues. But those are some of the things we think about. So why are we including the trapezius? Once you get into the mode of managing pain, in orofacial pain mode, you're going to want to go after all potential nociceptive input from all structures that can sensitize the trigeminal nuclei in the brainstem. And that includes the superior trapezius as well. So you've got, what does this do? Well, it elevates the scapula. It shoulder shrugging. Okay? Cranial nerve 11. So you've got to move shoulder shrugging. So a very easy muscle to palpate. With all muscles, you got to palpate enough, long enough, and hard enough. At least 5 seconds, 5 to 10 seconds. Otherwise, you won't get a referral pattern. You can't just push and ask if it hurts, because you might elicit pain, but if you don't hold it long enough, you won't elicit a referral pattern that may be the source of the pain referral. So you got to hold every palpation. My recommendation is, not my recommendation, it's the recommendation, DCTMD, you got to hold it long enough. I think 10 seconds would be a good number for everyone to shoot for. But it's got to be at least 5. The sternocleidomastoid. Oh, and if anybody's going to inject the superior trapezius, what do you got to be worried about? What's the concern? What's the concern it's a big, thick muscle. What are you worried about? What could potentially happen? What was that? There you go. It could happen. Never seen it happen personally, but that could be. That's why you got to really grip that muscle and make sure you're not going too far, too deep. Pneumothorax. Pneumothorax when it comes to this muscle, when you're dealing with the trapezius. The sternocleidomastoid. What does it do? What does this do? Well, it does 2 things. Turns the head and bends the neck. And bends the head. So when the head is turning, like you're looking over your shoulder to change lanes, it's actually the opposite side that's contracting. So if I'm turning my head to the left, the right side is contracting. When I'm bending my neck, it's the ipsilateral side, the same side that's contracting. The good news here is that it's easy to palpate. Okay, very easy to elicit a referral pattern. What we routinely trigger point this muscle. What I would be concerned with is Botox, because Botox does spread, and then you could have issues with breathing and swallowing. Those are some issues there. But other than that, you would treat it like any other muscle that could be painful with a trigger point or multiple trigger points. When it comes to all of these muscles that we're going through, barring some secondary cause that we're not going to complicate any of this with, and really makes up well over 90% of cases, you're dealing with a primary myofascial pain and myalgia. It's going to be with very conservative treatments. It's going to be with avoidance therapy, if someone is doing something, posture, chewing hard foods, chewing gum. And you're going to initiate stretching. You're going to use short-term anti-inflammatories, muscle relaxants maybe, short-term. And physical therapy. Got to find a good physical therapist that truly feels comfortable dealing with everyone. They have more experience with dealing with the neck down, a lot of back stuff, but you got to find someone who's comfortable even wearing gloves and getting in the mouth. That's what you got to be looking for. Now, going back to the masseter and looking at the anatomy here. Remember how we talked about the facial nerve? The facial nerve. And I talked about the zygomatic branch and about the eye. I want you to look and see what we've got. We've got the orbicularis oculi here. Right? And you've got the masseter so close by here. And we've got the zygomatic branch right here, right next to here. So you'll inject inferior, get no side effects. All of a sudden, you'll go a little bit too superior, and now you've got a patient who just cannot. So you're not going to get ptosis. You're going to get the opposite. You won't be able to close your eye. And people will be freaked out over that. And you've got to be there to say, don't be freaked out. It's the same. I always give the example on dental visits. When your lip does something funky, you're comfortable, you know it's going to go away, don't worry. Sometimes patients have to tape their eyes shut for 15 minutes. And when you're doing trigger points, or when we're doing trigger points, of course we don't use epinephrine. So it's not going to last anywhere near as long. This should resolve in as little as 15, 20 minutes, maybe half an hour. They should have the ability to close their eye. Imaging of the joint. Now, this is a really important topic. We want to make the best choice. That's why. We want to make the best choice. We don't want to just say, well, everybody gets an MRI, everybody gets a CT. What about everybody getting a pano? So the question is, what do I order and when? Painless click, no other symptoms, no imaging. There's no need. Has it been that way for years? Yes. It's very common. I've had this since I was a teenager. Nothing's changed. I know what I'm going to find. I know that the disc will be displaced on an MRI. It will confirm what I know clinically, and I'm not going to do a thing about it. It's not going to change my treatment. So the four main types of imaging that are available to us and that we're familiar with, we'll start with the Panorex. Some providers like to do this as a quote-unquote screening tool. I'm not going to say that shouldn't be done. I can totally see that if you're performing general dentistry anyway, this could be useful to you. Sure. But in terms of diagnosing temporomandibular, well, this is going to have nothing to do with any muscle conditions. We're focused just on joint-related issues. So what's a pano going to even show you? Bony changes. You can't see muscle on a pano. And not only that, but this is two-dimensional. So you're going to see very severe bony changes. You're not going to see the mild to moderate changes. So you're only going to see the really bad changes. So it is limited. What about a hospital CT? CT is what you use when you're concerned about arthritic or degenerative changes of the bone. If it has to do with a clicking joint, a painful clicking joint, a joint that you think is locked, CT would not be the primary choice here. Because the disc is soft tissue, and you're not seeing that on a CT or a pano. So this is for the crepitus cases. It's crunchy. It feels arthritic and painful in addition to pain. It's for the CT is for the cases of bite changes, of idiopathic condylar resorption. You need to be tracking. You want to track them year over year to see when it's finally stopped. Patient tells they come in with an open bite. And you're thinking, gosh, has it been this way? And the patient says, no, in the last year my bite's changed. So the bone has changed. I want a CT. So these are for the arthritic changes, not disc-related issues, disc dysfunction. When do you do cone beam CT versus hospital CT? When we're dealing with the TMJ, each and every time I would go with CBCT. The resolution is better. The radiation is not just 25% less. It's like 10 times less. It's many magnitudes less than a hospital CT. It's not even close. But the practical issue here is cost. That going through the patient's medical insurance with hospital scan might be beneficial as many compared to those who have a cone beam CT machine who charge cash. I mean, who has a cone beam CT scan? Oral surgeons. Well, now a lot of people do, but you know what I mean. Surgeons will have it, and they'll charge the patient maybe $300-400, which isn't that much, in the grand scheme of things. But if it can go through their medical insurance and it'll be treated as such, sometimes that's more cost effective. So, needless to say, hospital CT, we do send a lot of patients for that. Doesn't show disc either, so neither with the pano, not with the hospital CT, a lot of radiation exposure. Cone beam CT is really the gold standard when you're looking at bony changes in the TMJ. Still can't see the disc though. Still can't see the disc. I wouldn't send a patient for a cone beam CT if I thought that if there was a hard end feel. Patient was clicking and now they stopped clicking, so I'm thinking, okay, I know how this goes. The patient all of a sudden clicked and now they're not clicking and it was sudden, so I'm thinking maybe this disc is now blocking the condyle on one side. Cone beam CT, not my first choice, not really my choice at all. MRI is for soft tissue. It shows the bone too, so I don't want to make it seem like it has no sensitivity for arthritic changes. It does. It can do both. But when you're looking at the joint, this comes into play when your concern is a disc displacement. Disc displacement without reduction. We're doing neck. We do soft tissue neck MRIs. So this is for soft tissue. In the scheme of TMJ imaging, the vast majority of the time, let's just say it's going to be for disc-related disorders. Okay? It's by far the most expensive, though. There's a lot of pre-authorization that has to go through this to get this authorized sometimes. So it's that aspect. And typically, and the vast majority of the time, it's without contrast. You don't need contrast for TMJ. It's just going to be MRI, TMJ, no contrast, an open and closed position. Always get both sides. You got to get both sides. We know what a pano looks like. We know what it looks like. It is quite limiting. You have distortion, and you really can't tell if one condyle has shrunk compared to the other one unless it's quite significant. And this is a real nice pano actually, but a lot of times you have some interferences of other structures that make it difficult to see because it is a two-dimensional structure. It's a two-dimensional image. Here's an example of a hospital CT. The joints don't look great, especially on our right side. It's a great modality. Nothing wrong with hospital CT, if that's what we got when we're looking at degenerative changes. But lots of radiation too. And this is in contrast to our really good friend here, a cone beam CT. It is far more limited. Resolution is very high. And it is preferable. So, what do you notice with the MRI? I see something. Oh, I see something. I see the disc. See this? Remember how I said the biconcave? It's got that bulb. It's got the 12 o'clock position, the posterior part, depending on which way the patient's facing. In this case, the patient's facing to our, it's going to be facing to your left. So look what you got. You got the posterior band sitting right over the condyle. You have the anterior band here, and you have the intermediate zone here. Does everybody see that? This is really textbook. So in the normal situation, that's what I'm telling you. It's totally fine that the posterior band is sitting on top, right above the condylar head. So, and you can see that it's a little fuzzy around the edges here. It's not quite as good for bony changes, but you absolutely can use this for both. but it does a better job with soft tissue. And we'll wrap up. It's a question that's come up more recently about ultrasound just in general. We have an ultrasound. We vetted a few of them, these new handhelds. And I think it's interesting. It's really amazing what you can get in a unit that's $5,000 or less. It's kind of crazy what you got. The advantages now are the low cost. You've got real-time assessment. You're not sending a patient off to the hospital to get a scan. You can repeat it because you're just doing it. You just doing it. And if you don't see what you see, you can put some more gel and keep looking. It's very fast. It's instantaneous. And I put no risk, I guess, from a philosophical perspective. Nothing has no risk, but pretty much it's got no risk, It's got no risk. Now, the disadvantages are it's got quite a learning curve. It's no joke. It's best if you have some friends in high places that somebody can come in and show you how to identify the anatomy and just decipher between structures. So it does have a learning curve. It's very operator sensitive. With these handhelds especially, the sensitivity to discern small structures can be challenging. This last point is what we found. I wanted to do an EMG guided injection into the lateral pterygoid through the notch here. I can do it myself. I don't need any help. I need no help at all because the needle itself is the probe. Okay, like the needle is a special needle that's attached to the machine. So the needle is the probe. But if you're using this, you're going to use just a regular needle, and you got to have someone holding this ultrasound here. So now you got two things going on here. It's really kind of a pain. And this is it's not like the knee. I always go back to the knee because that's where a lot of these injections are done, hyaluronic acid, steroids, so forth. The knees actually has a lot of surface area. And you could, put the ultrasound on one side and kind of get a needle in. Try it here. You're virtually blocking where you want to inject. So it gets a little bit technique sensitive. But I don't want to discourage you. I think it's an interesting. It has a lot of uses, both educationally. Some people use it to try and decipher the occipital nerves, which is beyond the scope of this lecture. So it's got some good uses for it, and the probes are getting small. The head is getting smaller and smaller, so that it's still a good option. What about the evidence? Whether you're dealing with a handheld that's a few $1,000s, and they are really cost effective, and they are really that cheap now, as opposed to the $30,000 hospital ultrasounds, there's a big difference. We have faculty that have those, and there's still a huge difference in sensitivity. So the evidence here on just what can you see varies so much, both in terms of sensitivity of identifying structures and specificity as well, to not look at structures, to see what you want to see and nothing else. It becomes a little bit, it varies based on the type of machine. And what about in terms of actually using it for post-op pain? Like, is a guided injection with ultrasound helpful compared to using just landmarks? That's what I want to know. The evidence is still not clear on that. It's still not clear. Otherwise, we do a lot of joint injections, so I'm very interested in that aspect. So as of now, it's definitely not a standard of care. It's more of a nice to have, and it's up to the provider to use. And I know some providers do use them, and they're very happy with them. But right now, if you're injecting the joint, I'll go out on a limb and say 99% it's going to be on landmarks. And if you're doing a deep muscle, it's going to be probably EMG or landmarks. That's how that's done. Any questions? Please. Okay, so I'm being recorded here. So I'll say this. I have no sponsorship with anyone. I'll tell you, we looked at a couple of them. I'll just put it this way, the truth. We ended up going with the V-Scan Air, but we tested the others too, or I think pretty much all of them on the market. It's from G. It's called the V-scan air. Like that a lot. Yeah. Any other questions? Please.
We were talking about injecting into the master. Temporary problem with the zygomatic nerve is high. What if you're injecting Botox?
So I'll throw that back at you. We have to know what Botox does. Botox affects, what does it do? It prevents the releasing of acetylcholine. So if you're injecting Botox and it's in the muscle, then you're going to get the effect that you want. If you inject it in an artery or something or near a nerve, that shouldn't do anything. You're not going to inject inside of the nerve, you know? Because the whole point of Botox is that you're preventing the release of acetylcholine anyway. So you're not doing it in the nerve anyway. It's going to be either you're going to get paralysis or not. So it's not going to do anything to an actual nerve, so to speak.
Pretty much safe.
Yeah, you're just going to waste it if you get it into a vessel.
Sure.
Yeah. Any other questions? All right. Well then, we finished on time. Yay.